Alzheimer's is the classic progressive dementia. Patients usually start with short-term memory loss and slowly lose the ability to perform complex movements or tasks. Changes in the brain begin years before the appearance of symptoms. The progressive decline can be related to the accumulation of amyloid beta deposition within senile plaques or increased tau proteins. There is also the accumulation of alpha-synuclein, creating Lewis bodies. Amyloid beta interferes with neuron communication. Tau proteins creates neurofibrillary tangles that cut off nutrition to the nerve. There are two main forms of Alzheimer's disease: early onset and late onset. Early onset Alzheimer's is rare and usually linked to inherited autosomal dominant mutations. These often involve genes coding for amyloid precursor protein or related proteins that lead to excessive amyloid beta production and deposition. Late onset Alzheimer's is much more common and typically not tied to a strong family history. Environmental factors such as pesticide or heavy metal exposure may play a role. The most well-studied genetic risk factor is the apolipoprotein E gene. This variant can bind to amyloid beta in a way that promotes toxicity and accelerates plaque formation. So, Alzheimer's usually progresses in stages. In the early to moderate cognitive decline phase, patients start to slip up on small daily tasks, things like making coffee, balancing a checkbook, or following a recipe. It's subtle, but you'll notice a pattern. Later, when the dementia stage hits, the changes are much more dramatic. Now it's not just memory loss. You'll see personality shifts, behavioral changes, and a real loss of independence with everyday activities. When it comes to diagnosing Alzheimer's, we usually start with cognitive tests, the Mini Mental State Exam, or Montreal Cognitive Assessment. Imaging with a CT or MR, I can sometimes show cortical atrophy or even hints of plaques and tangles. And if you want more definitive evidence, you can check CSF for amyloid beta and tau proteins, or get a PT scan with amyloid tracers. For treatment of mild to moderate Alzheimer's, we usually start with the anticholinesterase inhibitors, donepezil, galantamine, or rivastigmine. These help slow down cognitive decline. Some clinicians will also add vitamin E for its possible neuroprotective effect, since it may reduce oxidative stress. When the disease progresses to a more severe stage, memantine becomes the go-to option. It's not unusual for patients to receive both memantine and donepezil as part of their treatment regimen. In recent years, anti-amyloid antibodies like donanemab have come onto the scene. These are designed to target and remove amyloid beta deposits from the brain. Beyond medications, supportive care is just as important. Occupational therapy, for instance, can really help patients maintain independence with daily tasks for as long as possible. Perfect pimp question. Besides Alzheimer's, what are the other major types of dementia? Lewy body dementia. Think visual hallucinations, Parkinsonian features, and waxing waning attention. Parkinson's dementia, similar, but the key is that the motor symptoms come first and dementia follows later. Vascular dementia, that classic stepwise decline after strokes or small vessel disease. Frontotemporal dementia, younger patients, usually with big personality or language changes. HIV-associated dementia happens in uncontrolled or advanced HIV and sometimes improves with ART. Also mention this to flag a high-pass recommendation: normal pressure hydrocephalus, wet, wobbly, wacky, prion disease like Creutzfeldt-Jakob disease, or Wernicke-Korsakoff in alcohol use.